Thank you for joining us today for the 5th Annual Policy Summit presented by the American Association of Kidney Patients. This year's summit is titled Patient Voice, Patient Choice, New Determinants for Kidney Policy. My name is Ed Hickey. I'm president of AAKP and serve as the chair of the Veterans Health Initiative. Professionally, I'm a veteran United States Marine Corps infantry officer. My public service career includes posts on Capitol Hill as an administrative assistant to a United States Congressman and a special assistant at the United States Department of Congress under George H.W. Bush. Following the terror attacks of September 11th, I also served as a senior advisor for Homeland Security for the Director of the United States Civil Service under President George W. Bush. Currently, I'm a practicing attorney in Los Angeles. I'm active in the armed forces legal community, working locally with the Veterans Legal Service Project of the LA County Bar Association to support the legal needs of active military personnel, reservists, and veterans. And at a personal level, I'm a fellow kidney patient. I'm also an experienced caregiver and patient advocate because of the history of kidney disease within my family. I'm pleased to introduce our session titled Critical Barriers to Care Transformation: How Payment Policies Impact Kidney Patient Consumers and Innovation Leaders. AAKP has, for over 50 years, been a champion for patient choice and innovation in kidney medicine, including therapeutics, diagnostics, and devices. That is why AAKP fights for solutions that help diagnose disease earlier, slow disease progression, and helps stop kidney failure. We are strong advocates for preemptive transplantation, greater access to kidney transplants for all patients in need, and home dialysis. AAKP defines high-quality kidney care as timely patient access to therapies that keep patients healthy and fully capable of pursuing their aspirations, such as maintaining a career in meaningful part-time or full-time work, starting a family, owning a home, and retiring securely. After decades of stalemate and little innovation, the kidney community is witnessing a golden era in kidney drug and device development. That is why, in part, AAKP declared the next 10 years is the decade of the kidney. In the past several years, the U.S. Food and Drug Administration has approved several new and safe treatments that help patients better manage kidney diseases and related conditions. AAKP anticipates more approvals in the coming years. These approvals require tremendous research, investment, patient participation in clinical trials, and advocacy. And to be clear, each FDA approval is a significant victory for kidney patients in need and the companies and researchers who have committed themselves to transforming status quo kidney care. Yet these victories are incomplete if patients cannot access the drugs and devices once the FDA has found them to be safe and approved for patient use. Patients, medical professionals in the industry are becoming increasingly frustrated by the cumbersome barriers to patient consumer access to the innovations patients have fought for decades. Some payers, including insurance companies, and at times the Centers for Medicare and Medicaid Services, or CMS, either intentionally or through a lack of understanding of the patient burden of kidney disease, erect barriers to access these FDA-approved treatments. In some cases, some payers do not support these innovations at all. AAKP believes access must be addressed now because access to future innovations will be negatively impacted if we are not successful in these initial fights. Fighting for patient access to new innovations takes courage, political sophistication, and the fortitude to win. This is why AAKP launched its Patient Voice, Patient Choice Initiative in 2022. Through this interactive platform, patients and care partners can quickly identify barriers impacting care, choice, and treatment. Through AAKP, patient consumers can engage elected leaders, government agencies, and payers to raise their voice when timely access to safe, FDA-approved treatments and devices are hindered by nonsensical barriers. Simply put, AAKP is 100% committed to making certain patients receive the right treatment at the right time based on the guidance of the doctors they choose to give them care. I'd like to now welcome Sharon Griff, Managing Director of the Griff Group. Sharon is a former board of director of the AAKP and a longtime patient advocate. She was a member of our board of directors when AAKP formally adopted our new national strategy, putting the organization on the path to an unprecedented level of growth over the past 8 years. Sharon, I turn it over to you.
Well, I really want to thank AAKP for having me come and speak today. My name is Sharon Griff, and I'm a registered dietitian by training, and I'm a market access consultant. And my role is to really make sure that patients have access to new products in development. I've been working in the field of kidney disease for over 25 years. Today's topic regarding how CMS policies impact innovation in the management and treatment of patients with kidney disease on dialysis is quite timely. There has been limited development in this area, and as a community, we need to work together to ensure that over the next 1 to 5 to 10 years, we're able to change this. So let's start at the beginning. The ESRD Prospective Payment System, also known as the ESRD PPS, went into effect on January 1st, 2011, about 11 years ago. At that time, CMS moved the payment for dialysis and related dialysis services, including drugs and labs, from a fee-for-service model where items were separately payable to a bundled payment model. All of the services would now be reimbursed under an all-inclusive bundled rate. There are many factors that go into this bundled rate, and it changes every year. At the time the ESRD PPS went into effect, CMS did not include any allowance or adjustments for new drugs coming to the market. As you can see from this slide, there have been 3 drug approvals and 4 drug launches since the ESRD PPS went into effect. Mircera, an ESA, was originally approved in 2007 and launched at the end of 2014. Parsabiv, an IV calcimimetic, was approved in 2017 and launched in early 2018. Retacrit, a biosimilar to Epogen, was approved and launched in 2018, and Korsuva, an antipruritic drug, was approved in 2021 and launched in 2022. There have been other drugs launched, however. These drugs are covered under the Part D benefit, not the ESRD PPS. I am sure many of you are aware that during this same 11-year period, the FDA has approved hundreds of drugs. However, only 4 came to market to treat conditions associated with dialysis. In this same time period, dozens of life-changing medications have been approved in oncology, neurology, and rheumatology, just to name a few. In addition, breakthrough technological advances have been introduced in many other markets. Let's dig a little deeper. As I said earlier, in the original ESRD PPS, CMS did not have any payment for new drugs coming to market. When Mircera was launched, it was covered in the bundled ESRD PPS rate from day one. In 2016, CMS introduced the Transitional Drug Add-on Payment Adjustment, also known as TDAPA. Originally, TDAPA was developed as a payment adjustment for injectable drugs that were not included in an existing functional category. Let me explain what a functional category is. The functional category is a system designed by CMS. It groups products into categories based on end action. For example, there is an anemia management category, which includes drugs used to stimulate red blood cell production and/or treat or prevent anemia. Currently, this category includes ESAs and iron. Overall, there are 11 functional categories developed by CMS. Parsabiv was approved in February of 2017 and launched January of 2018. Parsabiv and its oral counterpart, Sensipar, that had been on the market for 15 years, were the first 2 drugs to be covered under a TDAPA. At the time of its approval, Retacrit did not meet the criteria for a TDAPA and was covered under the bundled payment rate at launch. In 2019, CMS expanded the eligibility criteria for TDAPA to include new drugs that were included in functional categories, and in 2020, CMS refined the eligibility criteria further. In August of 2021, Korsuva was approved and was granted a TDAPA effective April 1st, 2022. Let's take a closer look at how TDAPA works. CMS uses the functional category to determine how drugs will be paid. If a new ESRD drug, and I'm looking at the first column, is in an existing functional category and meets the eligibility requirements, they will be granted a TDAPA. The TDAPA payment rate is ASP plus 0. The product will get this payment adjustment for 2 years. At the end of 2 years, the drug will be covered under the bundled rate and no additional adjustment will be made. If a new ESRD drug is not in an existing functional category, they will be granted a TDAPA. The TDAPA payment rate is still ASP plus 0. The product will get this payment adjustment for at least 2 years. CMS will collect utilization and cost information during this time period, and at the end of the TDAPA period, CMS will calculate a base rate adjustment and change the bundled rate to include this new product. But what does this mean for access to drugs? Well, pretty much any new drug that's going to come into market will fit into one of the current functional categories designed by CMS. There can be new drugs with new MOAs that are superior to current treatments, but the way the rule is written, this new drug would not receive a payment adjustment when the TDAPA period ends. This lack of long-term reimbursement significantly reduces patient access to new therapies. And finally, the payment rate itself. CMS reduced the payment rate for TDAPA drugs in 2020 from ASP plus 6%, which is the rate for separately billable drugs under other payment systems, to ASP plus 0. With sequestration, reimbursement is below ASP. It appears CMS has heard the challenges that patients and providers are facing in regards to long-term reimbursement and has recently requested feedback on a new payment proposal post-TDAPA. We are hoping to learn more next year. So why does the ESRD PPS and the TDAPA policy hinder innovation in kidney disease? Well, let's think about this. It typically takes at least 10 years to develop a new drug, and the payment mechanisms are constantly changing. There are so many unknowns. Will TDAPA eligibility change over time? Will the payment rate change? Will it be reduced again? Will there be long-term payment mechanism post-TDAPA? How will that rate be calculated? How long will the rate be available? Which drugs would qualify? And so many, many more. If you are a manufacturer determining where to invest your resources for a new product that will not be coming to market for 5 to 10 years, it is very difficult to justify investing in treatments for conditions associated with dialysis because the payment mechanism available when you start may not be available at launch. For example, Triferic Avnu, a treatment for iron deficiency anemia for patients on hemodialysis, was approved in March of 2020. Initially, the manufacturer believed that it would receive a TDAPA after the eligibility update for calendar year 2019. However, 1 year later, CMS changed the requirements and this product was no longer eligible for a TDAPA and launched directly into the bundle with very little traction. For providers, the current policies make it difficult to offer new drugs when there is no long-term reimbursement or no reimbursement at all. CMS does not require Medicare Advantage plans to pay a TDAPA for these new drugs. Unfortunately, this has resulted in very spotty reimbursement from Medicare Advantage plans for TDAPA drugs. This is a significant issue as more and more dialysis patients are choosing Medicare Advantage every year. No other provider type would be expected to provide treatment without payment. Unfortunately, in the end, it is the patient that loses. The patient may not have access to new drugs or may lose access to drugs they were already on. And finally, the patients suffer because few manufacturers are willing and able to invest in innovative products to treat patients on dialysis because that funding goes elsewhere. Just to give a quick example as to how the ESRD PPS compares to other CMS payment systems, as well as the impact the changes in TDAPA have had. You'll remember from earlier in the presentation, I mentioned Redicrit. Redicrit launched in 2018 under the former TDAPA guidance, so it did not receive a TDAPA. Under the new eligibility requirements, because Redicrit is a biosimilar, it would be eligible for TDAPA now. In addition, Redicrit is used to treat patients outside of dialysis as well, in oncology and in earlier stages of CKD. When used in these other sites of care, Redicrit is paid separately at ASP plus 6% of the reference product or ASP plus 8% of the reference product, with the latter rate being a result of a recent CMS policy change for biosimilars. As a reminder, when used for dialysis, it is included in the bundled payment rate. So where does this leave us? I think we would all agree that we would like to drive development of innovative products for kidney disease, including for patients on dialysis. And very importantly, we want to ensure all patients have timely and long-term access to the necessary treatments. And I'd like to make a comment regarding timely access. With the way TDAPA works, drugs are unable to launch at approval with a TDAPA payment. Therefore, in both instances where TDAPA was granted, drug launches were significantly delayed post-approval. In other disease areas, drugs will have reimbursement at approval and can launch right away. So how do we get to a place where policies support innovation, and is TDAPA really the answer? Well, unfortunately, I think I've demonstrated that TDAPA may not be the answer to support innovation. The kidney community and CMS need to work together to develop a holistic policy. The current process with adding a new Band-Aid every year or two is not working and is not sustainable. The policy must be comprehensive and consider today and the future. One of the reasons we are in this situation is that the current policy updates are reactive instead of proactive. Patients, providers, and manufacturers need to have confidence and clarity in these policies. Finally, issues and questions need to be addressed in a timely manner. The current CMS system of annual rulemaking ends up leaving a lot of unanswered questions and issues for months or even a full year. This uncertainty adds to the already tenuous position patients and providers face daily. Overall, I think the good news is that there is a lot of momentum for change. The kidney community is very active, dedicated, and experienced, and will be able to collaborate with CMS to develop new, comprehensive policies to address these issues. So I'd like to thank you for your time today, and once again, I would like to thank AAKP for having me speak today on this very important and timely topic. And I hope you have a great rest of the day. Thank you.
Thank you, Sharon. Excellent presentation on a very important patient access issue.